the Egyptian Society of Nuclear Medicine through Professor Husna and Professor Walid for their kind invitation to attend to this meeting in this great country with great history. I would like also to greet Al-Ghazar, my big friend for a long time, and I'm honored to be with you. Thank you. It's one of the pioneers of nuclear medicine in the Arab world, in Africa, and in the world. Thank you. Okay, so my talk today, it will be more classical. It will be about, with the new technology in myocardial perfusion and myocardial or cardiac imaging, what is the place actually of the conventional SPECT camera, Anger camera, in this new environment. So first, I would like to give some definition. The first one is to define the coronary artery disease, which is stable angina pectoris or other symptoms felt to be related to coronary artery disease, such as dyspnea. So it is a little bit polymorph. The second one is previously symptomatic patient with non-obstructive or non-obstructive CAD who have become asymptomatic with treatment and need regular follow-up. So this is one of the main stage, is the prognosis. So therefore, very important to identify those patients with a less severe form of disease and a good prognosis to avoid new unnecessary tests and revascularization procedures from those patients with more severe form of disease who may benefit from more aggressive investigation and potentially intervention, including revascularization. So the first one, I mean, the first things myocardial SPECT has demonstrated is that when the SPECT is normal, we have a very low rate of cardiac event, or even major cardiac event. And you can see this one, what it was is done by Iskander in 1998, and showing that when normal it's 0.6. And that one, in this study, it was 80 studies with a total of 63,000 patients. And so among that, the 0.6 is like general population. When it is abnormal, we have the percentage increased to 7.4. But showing that is the prognostic value of myocardial perfusion was strongly adopted. This one is another study. It's from Van Zetto. It's showing that he took a population of 387 patients, mostly men, 75, with the medium age of 55 years. And he followed them during 6 years. And he finds that almost when he's normal, cumulative cardiac survival was almost 100%. So this also showing the strengths of nuclear cardiology and the SPECT, the classical SPECT. So this one is started, SPECT, Anger started to be related to find some things, some links with the calcium score. We used to report, I mean, if you can see this one, okay, it's okay. Okay. We can see, we used to report this one ignoring the calcium score, we can have a normal one. We have had a normal. We have had normal myocardial aspect, but we report it as normal. It is not normal because the calcium score is playing also a role, and it is a variable, independent variable. So, coupling or accompanying SPECT, myocardial SPECT, conventional with calcium score, is an adding value. And we can see in the extreme, this one is normal, is okay, calcium score is 0, but here it's 1,200. We cannot see that it's even if myocardial perfusion appears as normal, it doesn't mean that it's in absolute situation, it is not really normal, but we have to do some additional investigation. And of course, we can see here that when we have abnormal SPECT, of course, the abnormal score is increasing about with the calcium score. More we have, the calcium score is increasing, then we have, there is a relation, but there are independent variables. And we can see it here. For example, here in normal SPECT, we have for calcium score above 1,000, we can see here that it's 15 days. Meanwhile, with the calcium score about is equal to 0, we have had 14. So there is no linear relation between them. The same for abnormal. We have here, for example, it's between 400 and 1,000 is 13, and then we have about 14, which is 100 and 400. So the threshold of the calcium score will be the 100 unit, Hounsfield unit. So, sorry, this one, there is problem of presentation here. I don't know. Just if you can remove it, because it's big, maybe there are something. Just, no, not only one, all of them. Okay, no problem. Let him like this. Like this is okay. And do it by bigger one, it's okay. Okay, so, no, maybe it's okay. So, we have, it's totally moving. Please. No. I have mine. I will take it from my memory stick, if you want. I have it. Take it directly from my memory stick. Yes, memory stick. Don't register it. Sorry. No, this one, cardiac, go down, 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 sorry, up, go up, go up, go up, sorry, go up. Let me see, sorry, I have to find this modification. This one. This one. I hope it's okay. It's okay. Put it on the big one. It's okay. It's okay. Like, good. Some problem. No problem. Yes. Okay. Okay, let me just push on the. Okay. So, it's a problem. So, I will continue with the cardiac CT angiography. Of course, with the cardiac CT angiography, one of the characteristic is that from his implementation in hospital, the numbers of myocardial perfusion SPECT referrals has increased because there is no, when it is normal is okay, but when there is a stenosis, he cannot determine with accuracy the flow, the myocardial blood flow. So this one, we send it for myocardial perfusion to look after the ischemia or not. And so the number of referral to SPECT MPI increased. But it is actually is considered is one of the best for exploring patient with pectoris angina symptoms, and then it is like considered as the first line. Then after that, we can see what we can do. So the other one, other investigation, which we have a strong relation with it, is the ultrasonography. Mostly the dobutamine stress echocardiography. It's very good. There is good relation between myocardial perfusion and stress dobutamine with echo. And we can see, for example, that it's in terms of predicting recovery of contractility, the DSE is almost in the same level that the PET with 83%, and comparing to the 76% for the myocardial SPECT. And there is a very good relation, and we have always in mind when we practice in nuclear cardiology and we do myocardial perfusion, we think about ultrasonography. Thank you. Of course, and with stress stimulation. So, and we have a lot of devices ranging from the classical gamma camera to the PET to the CZT camera and everything. So the first one, I'm sorry, I will just speak about because my slides, then there is some trouble. And so the first one, I will speak about CZT, gamma camera. So, I mean, I was meeting 3 weeks before in MDT for cardiac, and I have some question from colleagues telling that you are, so is it possible to do the revision to look after the myocardial blood flow? And the second, is it worthwhile to take a gamma camera, CZT? We call it cardiac dedicated camera. Is it really interesting to have it? So I would like to say about something about this. The first one is that, of course, the CZT, it is a tremendous advance in terms of detection, in terms of new technology. There is semiconductor. There is solid state detectors who have a very high rate of counting, very sensitive counting. There is no mobility at all. The collimator is taking image from the patient. It's not like SPECT-CT. So, as a consequence, most important consequence is that we'll have low time for acquisition for patient comparing to the SPECT-CT. So, I mean, we have this one. So now, why we are not eager to have it in a university hospital? First of all, is availability. Is it available in your country? Or? The second one is that is doing only cardiac. So if you are in the university hospital and taking a camera dealing only with cardiac, I mean there is something to argue with the management. The third one is that, of course, we need to have a very big activity, clinical activity, to get one camera only for heart. So we should have very big activity. In our department, we have reached about 4,000 a year. We were eligible, but I mean the other education has needs also to have they have priority. Of course, comparing to, and now it's becoming normal. That's good. Good news. So the rest and the stress MPI with SPECT anger with conventional is okay. It's still, but the CZT is becoming now one of the most advanced technology better. So there are currently two main commercially available. We have the DSPECT, the Spectrum, and the Discovery, GG. And of course there is no mobility, and the efficiency is 5 to 10 times the efficiency of the conventional anger camera. Of course, the advantage compared to the anger camera are similar for both, and spatial resolution, contrast to noise are very, very interesting. Of course, there is a study, I would like to show you a study, which comparing the diagnostic performance of conventional anger with cardiac dedicated camera CZT SPECT and this CZT SPECT CT2. There are three. And we have a three camera. So the first one, the second one, the third one, and the patient were done in using these devices. And of course, the activity for the anger camera was the biggest. It is 740 megabecquerel. We call it 20 millicurie in the end. The second one, it's 185 for the CZT. And the third one was about 9 megabecquerel by kilogram and at rest, and 3 megabecquerel during the stress. And of course, the outcomes was considered as positive for CAD whenever a coronary artery stenosis has been detected in coronary angiography, and any cardiovascular event was observed within a follow-up of minimum 6 months. So this is the first one. We can see that is group A, group B, group C. If we look for the positive predictive value and we look for the negative predictive value and the accuracy, we can see that the accuracy is almost the same. So it even higher with the group E, with the anger camera. But it's almost the same. The CZT, they have negative predictive value more higher, and we can see it in further one. So the first one is that, so there is similarity between the three. There is no big difference. The second one is that we can see in terms of acquisition time, of course, we have more time to spend with the anger camera. It's almost 1,200. And of course, the other one, they have 280 second, and then the other one is 480, which is very interesting in terms of clinical activity. We can do very fast number of patients. And of course, the second point, which is very important, is not negligible, is the effective dose. The irradiation to the patient is very low with group B and group C, with CZT gamma camera. So there is the two big advantage is to increase the clinical activity and to reduce the dose given to the patient, which is not negligible. Of course, there is another one, there is other comparison, there is another study done in 2023, published in the Journal of Nuclear Cardiology, is to compare the SPECT camera with CZT using cardiac MR as a reference method. And of course, the MI and the left ventricular volumes and ejection fraction using CMR as a reference method. And we can see here we have the first on above, we have the MI myocardial infarct on CMR. We have seen it 28, but and the CZT they see 28 comparing to the MR. And when there is no MI myocardial infarct on MPS CZT in 14 patients. So CZT patient also may miss the myocardial infarct. And in the same thing, there is no MI on CMR. There is no zero for MPS, which is very good. And no MPI, it was 31. Look now to the conventional MPS, Anger camera, the SPECT-CT. They have the same numbers, 28, 28, 14, 14, and 0, 31. That means that there is some similarity between the CZT and the Anger camera. And of course, the issue was in the definition, the site of the myocardial infarct, and we can see that it's almost they have the same, but the MRI, they have a better definition of the site of the myocardial infarct. So in terms of performance, Anger and CZT, they are doing almost the same. It's just a matter of location, location is the best. Ideally, is CMR. And we can see here, for example, as an example, we have the first one, we have an infarct in MRI and detected also by both. Above is CZT, and then below is conventional Anger. The second one, there is an enhancement, late gadolinium enhancement here on the right, on MRI, and we can see that it's both CZT and conventional are giving the same. They are not showing any myocardial infarct. And then the third one, we have infarct in MRI on the lateral, but we can see a little bit on CZT, but no in Anger. For this patient, the CZT has reported there is no MI for the reporting. So there is difference in diagnostic accuracy for detection of MI and assessment of left volume and left volume ejection fraction between MPS with CZT compared to conventional gamma camera. So they are small and do not appear to be clinically significant. There is another study comparing PET, CZT, SPECT, and conventional SPECT. That is very interesting because there is a future of MPI. Of course, PET MPI is already on playing a major role in some place. And of course, the study of patients undergoing nuclear cardiology imaging and followed for a composite outcome of all cause, death, myocardial infarction or late revascularization. So the MICE and the major event and late revascularization. So, an abnormal study was defined as a moderate to severe reversible defect in SPECT, and PET, a similar defect, additional to myocardial flow reserve less than 2. Okay, it's okay. So out of those patients, we have had 54 for SPECT, 32 for CZT, and 14 for PET, which is quite consistent. And the conclusion was, before the conclusion, we have abnormal study prevalence was almost 13% for SPECT, 12% for CZT, and 38% for PET. This is the biggest, the biggest issue is there. So in normal study, in PET and CZT, SPECT-CT has the lowest event rates, whereas abnormal PET study has had the highest event rates. It means that it's PET here, it's somewhere. We have to take in consideration the approach of the PET. So the PET outperformed both conventional CZT and SPECT-CT in assessment of incremental prognostic value. And if you can see here, we can see on the right low risk on green, on the orange is high risk, and you can see here that the PET and CZT are better identifying low risk, and for high risk, PET and CZT, PET first is outperforming from far, comparing to CZT and conventional source. And if you look after that, if you look to the curve between the red and the orange, the difference is quite important. It means that there is the significant difference between PET and SPECT. So, what is now about PET versus SPECT? We are now on the core of the discussion. What is the what are the actual strengths of the PET? So the first one is that it's clear, all of you have seen PET imaging. PET imaging are much better than SPECT imaging. That is something. That is due to the technology itself. It's not a matter of tracer, but it is due to technology itself. It's better resolution. And we can see even for the perfusion, this one study showing a quality, showing scans graded according to quality. We can see that it's in perfusion, in both stress and rest, PET is giving better quality image than the SPECT itself. And of course, for the gated, the difference is less. So the gated stress, get rest is also better with PET, but difference is minimized. So the reason we know them. The first one is the high count rate for PET, the very high count, improved spatial resolution, routine and robust attenuation correction on all scans, and the last one, image can be sliced at 3 millimeter for PET instead of the 6 millimeter. We cannot get below 6 millimeter, but there are some software, some SPECT-CT they may offer more, but in general is 6 millimeter to better detect multivessel disease. And the second one, the second big advantage is to quantify the myocardial blood flow. This is this is the one we are waiting really with a big hope, that it's the myocardial blood flow will be, of course, it is a reality for PET, also for SPECT, if possible, and for PET, it should have more accuracy. We'll see why before. So there is the reference method, that is something very simple to say. The reference method to measure the myocardial blood flow is the coronary angiography. This is what we do when we have intermediate to high risk. We don't know. We do coronary angiography. We measure in before and after, and then we can see that is the myocardial blood reserve, and then it will be a very important prognosis. It is invasive methods. So for the PET, the PET myocardial blood flow can be measured with the myocardial flow reserve, have proven incremental diagnostic and prognostic value. However, the reduction of the myocardial blood flow reflect the combination effect of, that is, we cannot distinguish. We will see that there is a protocol when we inject on bolus, we can see, but we cannot distinguish between obstructive epicardial coronary artery disease, diffuse atherosclerosis, and microvascular dysfunction. The three will reflect the decrease of the myocardial blood flow. So we are focusing on the epicardial artery. So that now we cannot do the difference. So there is a protocol, of course, of using for the PET perfusion. Most common now is the generator of rubidium. They do it. They can use the regadenoson, and they can use also the adenosine, and to measure the myocardial blood flow. And of course, they may even couple it to the FDG to look for the scar, of course. And both of them, they are considered actually as the best one to detect the viability. We can do it also if we don't have the adenosine. We have also possible to do the dipyridamole, which is less expensive and more available. So, in fact, after that, this is the protocol of the FDG, and combining both is appearing now to be one of the standard reference for detecting viability. The last part is the PET-MR. We have some excitement about this PET-MR in cardiology. And of course, it's, if we can take the hybrid imaging, offer the unique advantage of truly simultaneous in vivo molecular imaging and detailed assessment of myocardial function, viability, and tissue characterization, as both PET and MR component are integrated instead of working sequential such as PET-CT. So the MR is the soft tissue, of course, and this is considered as the reference for the myocardial infarct. So coupling these two, combining two, it could be very interesting. However, the generation of attenuation correction, AC, for attenuated and scattered annihilation is crucial and not yet well established. And of course, the second aspect, FDG, of course, is often elevated in the infarct zone in the first day following MI, and the extent of tracer uptake may correlate with increased chance of LV impairment on MRI after 6 months, independently of infarct size. However, this is between the functional imaging and the anatomical morphological imaging, represented by MR. You know, okay, in theory, FDG is not a fully cell-specific. And there is a physiological background uptake which requires careful and potentially time-consuming. So actually, at this time, there is a lot of development. We have seen in the last cardiology, European Cardiology Congress, there is a lot, they presented many things, but not yet fixed, but there are advances in most of them. Actually, they recommend to keep PET alone and MR alone, and then you do your reporting without having the same device. So in conclusion, I would say the conventional one, the Hanger camera SPECT CT is quite good. It's not bad actually. We can work with it. As because it's not, we are not doing bad things with it. This is okay. We may add to the SPECT MPI. We may add the calcium score. If you have the CT, better to couple with CT. So that is advanced. And of course, for the referral coming from the CT angiography, those one we have, of course, to know where the stenosis has been seen or where the stenosis have been seen, and then we can see keeping our objectivity without going to find to get exactly the same procedure, standard procedure to report the myocardial SPECT. Comparing to the CZT, in conclusion, for the CZT, those who have a high clinical activity, they may go for the CZT. It's advised. That is also the shortening time of acquisition and less irradiation to the patient. But you know, if you have a clinical activity ranging from pediatrics, from bone scan, infection and everything, so that one you need to have a SPECT CT. You have large. And the last, the PET imaging is one of the advances of the future for myocardial perfusion. If the myocardial blood flow, regional and the absolute, will be solved, I think the important move will happen. And PET MR, still very promising, and we are waiting for more consistent result. And thank you very much for your attention.